Good afternoon to our colleagues from the Philippine Society of Microbiology and Infectious Diseases, ably headed by its President, Dr. Marisa Alejandria, and our Vice President and overall Chair, Dr. Veglur Maginsay, and to the participants of the 42nd Annual PISMID Convention. First of all, congratulations on the 50th year of the PISMID, a society at the forefront of the Filipinos' fight against COVID and against infectious diseases in general. Thank you very much for inviting GSK to participate in this much-awaited annual convention. This year, our topic will be on antimicrobial resistance and COVID, specifically on antibiotic use during the COVID-19 pandemic and its implications for the future. As we all know, antimicrobial resistance is one of the biggest public health challenges that the world is facing for the longest time. And the Philippines is not exempt to this. In fact, WHO has declared AMR as one of the top 10 global public health threats that face humanity, and the main driver of resistance being the misuse and overuse of antimicrobials. In this COVID era, especially at the onset when data is still scarce on its treatment, excessive use of antibiotics were observed. We hope that through our symposium, we will be able to enhance our participants' knowledge on AMR and the appropriate use of antibiotics in COVID. For this year, and as always, GSK joins you in the fight against antimicrobial resistance. AMR is like a marathon, and it is a race that we intend to win. Thank you very much. Let me now introduce our esteemed speaker for this afternoon. Friend and colleagues, I am deeply honored to introduce Dr. Adrian Lijavetzki. He is a physician who specialized in pediatrics and infectious diseases, and he graduated from the University of Buenos Aires, Argentina. He currently serves as the Regional Medical Director for Infectious Diseases Therapeutic Area at GSK in Emerging Markets. He holds postgraduate degrees in pharmaceutical medicine and health technology assessment of the University of Buenos Aires and the Institute of Clinical and Health Effectiveness, respectively. His training and subsequent healthcare activity was carried out at the Center for Infectious Diseases in Buenos Aires. He has been a lecturer at numerous specialty congresses in Argentina and in some other countries within the region. He is an active member of the Argentine Society of Pediatrics, the Argentine Society of Infectious Diseases, and the Latin American Society of Pediatric Infectious Diseases. Without further ado, please welcome Dr. Adrian Lijavetzki to talk about AMR and COVID.
Hello, good afternoon, and thank you very much for the invitation to participate in this Congress. Over the next few minutes, I will present a topic of interest by these days, which is related to the potential emergence of antimicrobial resistance by the inappropriate use of antibiotics in patients infected with COVID-19. These are my conflicts of interest. I'm a full-time employee at GSK, and I currently hold the position of Regional Medical Affairs Lead in Anti-Infectives. This is the agenda of my talk. We will see what the global challenge of antimicrobial resistance is and what is the impact of this epidemic on antimicrobial resistance. We will review the concept of bacterial co-infection in the current and in previous pandemics. We will review some concerning data regarding the overuse of Acetomycin during the COVID-19 pandemic. Towards the end of the presentation, I would spend some minutes on SOAR study, which is an antibiotic surveillance study on community-acquired respiratory tract infections. For some years now, some publications and notes in specialized media have been alerting us regarding the risk of antimicrobial resistance and its potential impact on the treatment of infections in the medium and long term. While this is something we have been seeing for a long time, especially in patients with severe infections, we are increasingly going to start seeing it in mild infections, and what was previously easy treatable is going to be a challenge for medicine like it was a long time ago. The WHO expressed itself on this issue in a fact sheet this year calling for reflection. AMR is one of the biggest threats to public health. We know that antimicrobial resistance is rising dangerously worldwide. Over-the-counter antibiotics and the overuse of antibiotics due to the absence of clear treatment guidelines in some countries will lead us to enter in the post-antibiotic era where common infections could become fatal again. These are the results of the final O'Neill report commissioned by the UK government, which gives us an idea of the impact of AMR and makes a prediction for the future that can be frightening in some way. If we fail to reverse this current trend by 2050, 10 million people will die as a result of microbial resistance and will far outweigh other causes of death such as cancer. In addition, the cost to the health system would amount to $100 trillion. So far, this was all very well known. This year, very quickly, new headlines began to appear linking COVID-19 to the previous global threat of AMR. However, since the beginning of COVID-19 pandemic, the misuse of antibiotics increased and the situation got worse very quickly. Just look at these new headlines in the press. COVID-19 is speeding our march towards an antibiotic-resistant catastrophe, or COVID gives rise to potentially deadly secondary infections, antibiotics-resistant superbugs. We have known for many years that prolonged use, overuse, and inappropriate use of antibiotics leads to increased antibiotic resistance. There are 8 basic principles of appropriate antibiotic prescribing that need to be followed to reduce the risk of AMR. I would like to highlight the first and the last one on this list. The first one, treat only bacterial infections, not viral. And the last one, prescribe empirically but intelligently, always thinking about potential pathogens that could be causing the infection. Despite being COVID-19 a viral infection, high levels of antibiotics use have been consistently reported throughout the pandemic. And this is due to the lack of knowledge regarding the low potential for bacterial co-infection in this group of patients, mainly in those with mild to moderate infection. Now let's look at an interesting publication regarding the use of different drugs during the pandemic. According to this survey done in more than 200 frontline physicians, antibiotics rank second in terms of prescription after antipyretics such as acetaminophen. The survey showed that antibiotics like bronchodilators account for 40% of prescriptions in hospitalized patients with COVID-19. And how are antibiotics being used in COVID-19? Antibiotics are used for a wide range of reasons. They can be prescribed as part of a clinical trial, for example, Acetomycin, which is used alone or together with hydroxychloroquine. They can be prescribed as treatment of suspected bacterial co-infection. They can be prescribed as management of secondary nosocomial infection or secondary co-infections, or as a preventive medication in people who self-medicate. Many times, patients who develop a viral respiratory infection are co-infected with bacterium, which increases the risk of mortality. In pandemics in the past, such as influenza H1N1 in 2009 or during 1918 influenza pandemic, it was very common to observe bacterial co-infection, often by Streptococcus pneumonia. Now, what is the co-infection rate in the current COVID-19 pandemic? Let's take a look at the publications that address this topic. In this meta-analysis by Langford and some others, the author assessed the rate of co-infection and secondary infection in patients with COVID-19. It included 24 studies with more than 3,000 patients with COVID-19 between December 2019 and March 2020. Only 3.5% had an initial bacterial co-infection at the onset of the disease, while 14.3% developed a secondary infection after diagnosis. While we can see that the rate of bacterial co-infection and superinfections are low, nearly 72% of patients received antibiotics during their disease. Apart from Langford's meta-analysis, there is another one which analyzed 30 studies with more than 3,800 patients and where the co-infection rate was from 7 to 14%, while more than 90% received empirical antibiotics. Conclusions from the authors of the publications were unanimous in their view that there is no evidence to support the routine use of antibiotics in patients with COVID-19. In addition to these two meta-analyses that we reviewed recently, there are an increasing number of studies reporting an overuse of antibiotics in patients without a bacterial infection. In a recent study in the USA, patients receiving antibiotics were older and in more critical condition. Testing showed that 96% of patients who received antibiotics only had an infection with SARS-CoV-2 without a secondary bacterial infection. The authors of this study concluded that COVID-19 do not need antibiotics just in case. How azithromycin is being used during the pandemic? Several studies have reported in vitro antiviral activity of azithromycin with various mechanisms of action proposed, such as interference with the viral entry. Azithromycin has been proposed as a treatment for COVID-19 alone or with hydroxychloroquine, although to this day there are no randomized and well-controlled clinical trials supporting this indication. Major public health organizations, drug regulatory agencies, and scientific societies do not recommend the use of azithromycin as a drug to treat COVID-19 infection unless bacterial superinfections occur. Although azithromycin is a good antibiotic, it has a long half-life, so be careful when indicating it for the potential adverse events of this drug. We know that, like other macrolides, azithromycin has an arrhythmogenic potential, and some reports describe QT interval prolongation, torsade de pointes, and polymorphic ventricular tachycardia. The risk is increased by combining azithromycin with hydroxychloroquine or chloroquine, as several medical societies warn. The unrestricted use of azithromycin during the COVID-19 pandemic has raised concerns about the emergence of macrolide-resistant microorganisms. Before the pandemic, several surveillance studies around the world showed reduced susceptibility to azithromycin, and this situation is aggravated during the pandemic. Several studies have shown that use of azithromycin results in rising level of macrolide resistance. What about the susceptibility of Streptococcus pneumoniae to macrolides? Several studies showed that indiscriminate use of azithromycin was associated with increased resistance to macrolides. SOAR is a longitudinal and multinational epidemiological surveillance study with focus on pathogens causing respiratory infections. Towards the end of the presentation, I will show some interesting data from SOAR study conducted in Philippines. In this graphic, SOAR data shows the widespread of azithromycin resistance amongst Streptococcus pneumonia throughout the world. In orange, we can see the susceptibility of Streptococcus pneumonia to co-amoxiclav, while in green we can see susceptibility to azithromycin, which in some countries became as low as 20% or less, for example in Vietnam. Every 2 years, the WHO updates the essential medicines list to assist in the development of tools for antibiotic stewardship. 3 categories have been developed within this list: access, watch, and reserve. In the access group, we can find antibiotics widely available, affordable, and quality assured as amoxicillin, amoxicillin clavulanic acid, and amikacin. In the watch group, we will find antibiotics with higher resistant potential and which should be prescribed only in specific and limited situations such as macrolides and fluoroquinolones. And finally, we have the reserve group, where we will find antibiotics that should only be used when other alternatives have failed, for example, Astronam and 4th and 5th generation cephalosporins. It is important to highlight that azithromycin is in the watch group and should be used only under specific situations. Now let's review some guidelines such as the NICE and the WHO recommendations regarding the treatment of respiratory infections precisely for the treatment of bacterial pneumonia during the pandemic. NICE recommendation for outpatients with pneumonia is not to prescribe antibiotics if COVID-19 is the likely cause or if symptoms are mild. And it does recommend prescribing antibiotics if the likely cause is bacterial, the cause is unclear, or if there is a high risk of complications. For hospitalized patients with pneumonia, recommendations include to start empirical antibiotic if there is clinical suspicion of bacterial infection, and we need to review this indication as soon as test results are available. We need to stop antibiotics if the pneumonia is due to COVID-19 and with no evidence of bacterial infection. And as always, we need to review the microbiological results and switch to a narrower spectrum antibiotic if appropriate. NICE have also produced some summary tables as part of the COVID-19 rapid guidelines to guide decision-making about antibiotic choice in patients hospitalized with CAP. As we see in this table, there are alternative recommendations depending on the route of administration we should use. In patients with moderate or severe pneumonia who may be given oral medication, the best alternatives are doxycycline or amoxicillin clavulanic acid with clarithromycin. In the case you have to use the IV route, the options are AMC with clarithromycin or cefuroxime if there is a penicillin allergy. In both cases, fluoroquinolones should only be used if other options are unsuitable. In the case of hospital-acquired pneumonia, broader antibiotics should be used such as piperacillin, tazobactam, ceftazidime, or levofloxacin in case we have to use the IV route. For non-severe pneumonia, we can use doxycycline or amoxicillin clavulanic acid. WHO recommendations are aimed at discouraging inappropriate use of antibiotics as it could lead to increased bacterial resistance during and after the pandemic. That's why they only recommend an empirical treatment in cases of moderate to severe pneumonia with suspicion of bacterial infection and with a daily evaluation to stop therapy as soon as possible. I would like to take the last minutes of my presentation to review with you new antibiotic surveillance data on respiratory infections which were published early this year. What should be the objectives of an antimicrobial surveillance study? The results of an antimicrobial surveillance study should serve as evidence to inform treatment guidelines, antimicrobial policies, track antibiotic-resistant trends, and to educate on antimicrobial resistance. What is the importance of surveillance studies on respiratory tract infections? We know that low respiratory tract infections are the most frequent global cause of deaths due to infectious diseases. Rising AMR is a serious problem complicating respiratory tract infections management. And in most of the cases, RTI's treatment is usually empiric, so neither the pathogen nor susceptibility is known. There are several types of antibiotic surveillance studies, led either by academic institutions or by the pharmaceutical industry. In the case of studies led by institutions, I can mention the GLASS study led by the WHO, for example. Among the studies led by the pharmaceutical industry, I can mention as an example the studies SOAR, MYSTIC, ATLAS, and PROTECT. I will refer from now on to the SOAR study, which means Survey of Antibiotic Resistance, and is led by GSK. The SOAR study, as I mentioned before, is a multinational and longitudinal program which has been taking place in different countries since 2002. The primary focus of the study is testing the two major community-acquired respiratory tract infection-related pathogens, Streptococcus pneumonia and Haemophilus influenzae. The results are analyzed according to the three recognized and standardized methodologies, CLSI, UCAS, and PKPD breakpoints. This allows review of the results according to the most appropriate breakpoints for local circumstances, as well as aiding comparisons with other centers, countries, regions. The SOAR study allows to isolate bacteria from different places, depending on the type of infection, as you can see in this slide. The samples come from sputum, endotracheal aspirate, middle ear effusion, sinus aspirate, and bronchoalveolar lavage. Blood samples were also allowed in some patients with certain community-acquired respiratory tract infections. I will now refer to SOAR Asia cohort, held at 5 centers in Vietnam, Singapore, Cambodia, and the Philippines, from 2016 to 2018, and published in April this year in the Journal of Antimicrobial Chemotherapy. This is the antibiotic panel used in the SORA study. As you may see, the most prescribed antibiotics in the treatment of respiratory tract infections in the community were included. Penicillin, cephalosporin, macrolides, sulfonamides, and fluoroquinolones were evaluated against Streptococcus pneumonia and Haemophilus influenzae. In this graph, we can see that most of the isolation of Streptococcus pneumonia in the SORA Asia cohort came from blood and sputum samples. In almost half of the cases, out of a total of 260 isolation, samples came from pediatric patients. In this graph, we can see that the susceptibility of Streptococcus pneumonia against the antibiotic panel tested using CLSI breakpoints. These are the results for Philippines, where we can see an excellent susceptibility of Streptococcus pneumonia against amoxicillin clavulanic acid as well as against some other antibiotics. Something similar happened in Cambodia. In Singapore and Vietnam, susceptibility of Streptococcus pneumonia to AMC and to amoxicillin was much lower, near 75%, but at least 20% higher than to any other antibiotic except fluoroquinolones. In the case of Haemophilus influenzae, most isolations were obtained from sputum samples, 45%, followed by blood samples. Here the samples were obtained mostly from adult patients, followed by children and the elderly. Similarly, when we analyze Philippine samples only, we see that Haemophilus influenzae susceptibility is close to 100% for most antibiotic tested except sulfonamides. So let's move on now to the conclusions. I would like to close my talk with some key messages regarding the management of respiratory tract infections during the COVID pandemic. The first one, rising AMR is one of the biggest threats of global public health. The excessive use of antibiotics in the management of COVID-19 is contributing to rising level of AMR. Antibiotics overuse has other consequences such as gut microbiome disruption, which reduces the patient's ability to fight the infection. Antibiotic overuse is compounded by widespread of Acetomycin use as an investigational COVID-19 treatment. Major public health organizations, drug regulatory agencies, and scientific societies do not recommend antibiotics for the treatment of COVID-19 unless for a proven concurrent bacterial infection. And coinciding with the author of one of the publications, my last message is antibiotics are not needed in COVID-19 pandemic, just in case. My hope is that we can continue to learn more and more about this new disease to optimize its management and to reduce its impact on the health of our patients. Thank you very much for your attention.
Okay, good afternoon. Good afternoon, colleagues. Good afternoon, again, Dr. Adrian. First of all, thank you. The facts, the figures presented were truly a reminder of what pandemic we will face in 3 decades if we are not to act now. We should act individually, as an organization, in a country, and as people of the world. It's also good to hear that even during this pandemic, where a lot was unknown, especially at the beginning, we are now guided as we gather more information from all available sources. Also, I would just like to share with you that the Philippines has also made strides since the 2012 WHO AMR situation analysis. So most of the HCPs here are the ones implementing the plans to combat AMR and they are part of the hospital antimicrobial stewardship programs. I think all of us here are in agreement of the importance of surveillance as one of the pillars in the fight against AMR. So recently, our Department of Health has released its Antimicrobial Resistance results for 2019. And like the GSK source or survey of antibiotic resistance data, it includes the relevant pathogens for like Streptococcus pneumonia and H. influenza. So for some questions, Dr. Adrian, if we may. So you told us about the misuse of antibiotics during this pandemic. Has there been any change in this trend from the beginning of the pandemic to the present? So that's the first question. And then, what is your attitude to azithromycin used for prophylaxis during COVID-19 pandemic? And what are the possible consequences that we can expect?
Well, thank you, Dr. June, and good afternoon again. Well, you know that at the beginning of the pandemic, there was a lot of misinformation regarding the management of the disease. And this was evolving over the months. And although there are still many things that we don't know about this new disease, there are some others that we do know and that we are learning to manage. Regarding treatment, almost from the beginning of the pandemic, many clinical trials were initiated with conflicting results regarding the use of chloroquine or hydroxychloroquine, with or without azithromycin. And while some studies with few patients and not entirely well designed from a methodological point of view showed a decrease in hospitalization and death rate, other studies showed that there were no differences between the intervention and the control groups. As we saw during the presentation, azithromycin has been proposed as an alternative treatment or prophylaxis, although to this day there are no randomized and well-controlled clinical trials supporting these indications. And as we also had the opportunity to review during the presentation, not only there is no clinical benefit, but we also may expose the patient to adverse events and contribute to the emergence of macrolide-resistant microorganisms. And this only contributes to aggravating the situation since, as we saw in the SOAR study, resistance to macrolides has been increasing in recent years. And finally, remember that many scientific societies do not recommend the use of azithromycin as a drug to treat COVID-19 infection, as we could see in the presentation. And bacterial superinfection rate is low and even lower in patients with mild to moderate disease.
Okay, so thank you for sharing that answer, Doctor. So you mentioned SOR, and it mainly focused on Streptococcus pneumonia and H. influenza. I think as an EMT, it's a very common pathogen in the diseases that we see, and also for our specialist that's here with us today. So, what can you say about atypical pathogens? How important is their role in community-acquired respiratory tract infections? And do they develop resistance as well?
Well, you know that while Streptococcus pneumonia is the most common bacterial cause of pneumonia at any age, Mycoplasma pneumonia is also a common cause, accounting for almost 15% of cases in children over 5 years old. And this proportion increases with age, being almost 25% in adolescents and even more frequent in the adult population. Most Mycoplasma pneumonia infections are self-limited. However, clinicians routinely treat pneumonia caused by Mycoplasma pneumonia with macrolides, which are considered the treatment of choice. But we need to practice a judicious use of macrolides due to the emergence of macrolide-resistant strains of Mycoplasma pneumonia. We know that resistance to macrolide has been emerging for the last 2 decades, and this type of resistance has been seen in some countries in Asia, where resistance rates have been up to 90%. The United States and Europe have also reported macrolide resistance, and its prevalence in Mycoplasma pneumonia may be around 10%. So the answer is yes, they develop resistance, and we need to use macrolides only under certain circumstances, as indicated by the guidelines, especially now during the pandemic, where there is an overuse of macrolides, which will undoubtedly have a major impact on antimicrobial resistance.
Okay, thank you. So basically, this what we're saying is applicable to all possible bacterial infections and also the use of these antibiotics as well. So, for example, we receive a patient with signs and symptoms compatible with a lower respiratory tract infection. So how would we differentiate a viral from bacterial pneumonia?
Well, it is a very good question, and it is probably one of the most difficult decisions to make. However, currently we already have rapid diagnostic method to rule out or confirm COVID-19 infection. There are some other clues that could help us think about one or another etiology. For example, NICE released a COVID rapid guideline for managing suspected or confirmed pneumonia in the community. You have to consider a COVID-19 viral pneumonia if the patient has typical COVID symptoms for about a week, myalgia, anosmia, headache, exposure to known or suspected COVID patients, and you have to consider a bacterial cause of pneumonia if the patient becomes rapidly unwell after a few days of symptoms, if the patient doesn't have a history of typical COVID symptoms, or if the patient has pleuritic pain or purulent sputum. So there's a lack of rapid diagnostic tests to differentiate viral from bacterial infection, and at the same time, there's a need to identify new biomarkers to rule out or confirm bacterial superinfections.
So it's still basically, at the beginning, our history taking is still very important, and then later on, we use the available diagnostics, whether they are the traditional or the molecular ones. So is there a role for acute phase reactants to differentiate viral etiology from bacterial during this pandemic?
Well, you know that there has been much discussion regarding the utility of acute phase reactants. Acute phase reactants like ESR, CRP, or PTC always helped us to make decisions for clinical practice. They represent a complement to clinical evaluation and have an important role for differential diagnosis and as prognostic marker. In the case of procalcitonin, there are limited data that indicates that may be elevated in patients with COVID-19 without bacterial co-infection, especially if they have severe disease. That is why today it is difficult to be able to rely on this type of biological markers to make a decision regarding whether to prescribe antibiotics or not to prescribe them.
Okay, so even with all this available new things that we have in the laboratory, it's still very difficult. So some studies actually suggest that early treatment in patients with mild COVID-19 disease could be counterproductive. Can you share us your opinion about this?
Yes, you know that during the presentation we reviewed the NICE and the WHO recommendations regarding antibiotic prescription. The recommendation would be not to treat patients with mild symptoms with antibiotics and only treat those with moderate infection and suspected bacterial superinfection. Hospitalized patients with severe symptoms should always be treated with antibiotics early, there's no doubt, and then de-escalate based on the results of the cultures and laboratory findings. And there are some studies showing that early antibiotic treatment in non-severe patients may produce an imbalance of gut microbiota and release pro-inflammatory factors. So reducing early antibiotic treatment may reduce the risk of a secondary bacterial infection.
Okay, so thank you. So really, the microbiome is like it's quite a new thing, but it's really important to consider the effect of antibiotics to other parts of our body. So a lot of healthcare practitioners here in the Philippines actually rely on guidelines for antimicrobial management. How do you think COVID will reshape the guidelines, especially with the use of antibiotics?
Well, first of all, glad to hear that most doctors in the Philippines rely on guidelines for antimicrobial management. Unfortunately, in many countries, this is not the case, and there are many factors that affect the prescription of antibiotics, including cost and availability. However, certain precautions must be taken when choosing a clinical practice guideline. In some countries, there are national guidance prepared by local scientific societies with updated local antibiotic surveillance information. And in my opinion, these are the best guidelines to follow. Ideally, these guides should be updated every 3 to 5 years, since resistant patterns can change very quickly, and we should be aware of this trend. Certain consideration must be taken when using international guidelines, since in many cases, such as the IDSA guides or the NICE or the BTS, They are made with surveillance data from specific countries such as the United States or the United Kingdom. And finally, to answer to your question about how COVID will reshape guidelines, it is difficult to know yet, but I think the pandemic should make us all reflect and rethink the way we are using antibiotics today and how to preserve them for the future.
Okay, so really surveillance is a big thing before COVID, during COVID, and especially after COVID. So AMR has been an impending threat, as we've mentioned, even before COVID. What is now the biggest watch out regarding AMR that we are in the middle of this pandemic?
Well, I agree with you that this current situation is only going to make things worse. Despite being COVID-19 a viral infection, high levels of antibiotic use have been reported over the last month, and this is due to the limited knowledge regarding the low potential for bacterial co-infection in this group of patients, mainly in those with mild to moderate infection. As we saw in the presentation, very few patients had a bacterial co-infection early in their disease, and a relatively small number developed a secondary infection after diagnosis. In the two systematic reviews, we analyzed more than 70% of the patients had received antibiotics during their illness. And this overuse of antibiotics may lead to increased resistance to antibiotics from now on, which will be a more significant and lasting impact after the pandemic.
Okay, so thank you again. So talking about AMR, sometimes we may become too clinical or too scientific. So how can we what's the best practice to discuss this, and how should we educate our patients?
Well, it is an excellent question. I have no doubt that we must now redouble our efforts to fight antimicrobial resistance. There are many things that can be done to reach the community with clear and simple messages. In several countries, GSK has teamed up with academic institutions to spread messages on how to avoid AMR. Today, social networks are essential for this purpose. However, awareness campaigns must cover multiple channels to reach different groups. And probably the most important advice that can be given to a patient is never to start an antibiotic treatment on their own without consulting his or her treating physician, and of course, always follow their instructions regarding duration of treatment.
So first would be really not to self-medicate, and of course, adherence to treatment. Okay, so among the 8 principles of appropriate antibiotic prescribing, they go hand in hand in our fight against AMR. But if you were to choose one principle, what would be the most relevant or the most impactful for you, and what's a convenient way for us to apply this in our practice?
Well, it's difficult to have to choose just one, just because the 8 WHO principles were thought together, and all must be applied to combat AMR. If we take into account that most of the antibiotics that are prescribed in humans correspond to the first level of care, that is where we have to focus. If I had to choose only one, it would be prescribed empirically but intelligently, since most antibiotics are prescribed empirically, without knowing the etiologic agent or the susceptibility. And that is where the clinical practice guidelines should use updated information from local surveillance studies to make the most appropriate selection.
Okay, so sorry I had to put you in the spot with that question, but I think it's something that we can really do in our practice. So thank you for your answer. And probably one of the last question is, how can you share about what GSK is doing to contribute fight AMR globally, and are there any other special projects for the Philippines in the coming future?
Well, you know that GSK is strongly committed to fighting AMR, and this is demonstrated through several years of supporting awareness campaigns, antibiotic surveillance studies, and research and development of new antibiotics and vaccines. As I mentioned before during my presentation, GSK has been conducting the surveillance study in several countries since 2002 to understand how antimicrobial resistance evolves. And in the Philippines in particular, we were able to observe that susceptibility to antibiotics for the treatment of respiratory infections such as amoxicillin clavulanic acid continue to be effective.
Okay. Again, thank you very much, Dr. Adrian, for taking time. I know it's very early in your country, but again, thank you very much for accepting our invitation. It was truly our pleasure, and hopefully, when the pandemic is over, you'll be able to come and enjoy the Philippines.
Thank you very much, June, and thank you all. It has been a pleasure to be part of this Congress.
Okay. So again, unfortunately, we are running out of time. But if you have some other questions, you can actually send us an email. And also thank you again for your participation. Again, thank you, Dr. Adrian, for that discussion. And for some reminders and the closing remarks, may we call on our partner from GSK, Mr. Christian Vinalon. Ayan? Ayan?
Yes, Doctor, good afternoon. So I'm just waiting for
Okay.
my video
Thank you.
before I'll proceed. All right, so good afternoon, everyone. So again, my name is Ian Vinalon. So I'm the Customer and Marketing Manager for Anti-Infective here at GSK. Thank you, our dear doctors, for your kind attention. Also, a big thanks to our colleagues, my colleagues, our speaker, Dr. Adrian and Dr. June, for sharing their expertise and insights on how we can fight AMR in this time of pandemic. AMR, or antimicrobial resistance, which causes around 700,000 deaths per year, is currently the most alarming issue for human health. A recent high-profile report estimates that by year 2050, 10 million people will die every year due to AMR, unless a global response to the problem is mounted. As antibiotic resistance increases, it has the potential to have similar or even greater impact to society as seen due to COVID-19. Furthermore, although COVID-19 is caused by a virus and should not be treated with antibiotics, this pandemic is increasing the threat of AMR. Again, we have to use our antibiotics appropriately. There is no shortcuts on our road to recovery, and let's act now. At GSK, we are committed to fight AMR. Next slide, please. With our efforts to invest in newer therapies, local surveillance data, and widespread awareness campaign for all our stakeholders that leads to appropriate antibiotic usage and consumption. And lastly, we will continue to innovate. And this afternoon, I'm excited to share with you that your innovator Augmentin continues to innovate. The new format Augmentin Completo Pack in 21 tablets is now available to your leading drugstore nationwide. Your Augmentin Completo Pack comes in 21 tablets, good for your patient who needs TID 7-day antibiotic treatment. This will help them complete their medication as prescribed and ensure complete bacterial eradication, optimal outcome, and most importantly, prevent future resistance to antibiotics. So, the question is, how much is Augmentin Completo Pack? At the price of 880 pesos, your patient will get a complete 7-day, thrice-a-day treatment for infections. Compared it to a branded generics that will cost more than 1,000 pesos. Your Augmentin Completo Pack is the same Augmentin that has treated millions of patients for over 30 years. So, doctor, on the next slide, please. So, next slide. So, doctor, for your patients who are suffering from infections and who need 7-day treatment of co-amoxiclav, make a strong start for optimal outcome and against AMR. Finish strong with Augmentin Completo Pack. And together, let's help our patient do more, feel better, and live longer. On the next slide, so in GSK, we strive to be better every day. I would like to ask everyone for your feedback on how we perform on this afternoon's lecture. Your feedback, regardless positive or something for improvement, will really make this afternoon exceptional for us. So I'm inviting everyone to access Pigeonhole in your screen right now. It will only take you less than 2 minutes of your time. So again, thank you for your feedback, and we're looking forward for it. Next slide. And to know more about GSK products and even updates on our therapeutic area and upcoming webinars, we have our GSK Pro. So you can visit our GSK Pro. Registration is free, and you'll learn a lot about our disease therapy area and some updates about our product. So again, our dear doctors, for Peace Meet organization, congratulations on your conference, and may you have a fruitful week ahead. And to formally close this meeting, I would like to call in Dr. Mark Pasayan, the organizing committee chair for audiovisuals.
Hello, can you hear me?
Yes, doctor.
Hi. Yeah, good afternoon, everyone. And on behalf of the Philippine Society for Microbiology and Infectious Diseases, I'd like to thank Dr. Adrian Lijavetzki for sharing his knowledge and expertise on AMR. Given that we have a pandemic right now, the more that we need to be careful with our antibiotics and make sure that our antimicrobial stewardship program is in place. Also, would like to thank GSK for joining us in this annual convention. Thank you for the support, and hope you enjoy the rest of the program for today. Thank you again, and stay safe.